All right. I first want to just express my appreciation for allowing me to speak here. I'm not just appreciative of Mr. Farrington for inviting me to speak, but for providing this group, this organization, and providing the men who attend these talks to avail themselves of some education, to arm themselves to get better care and to tamp down some of these disparities that Dr. Crawford and Dr. Carter have talked about. As I was preparing my talk, I was thinking, where would we be without FEN and organizations like this, bringing prostate cancer disparities to the forefront? I am dressed like a surgeon today, like Mr. Farrington said, because I'm on call. So forgive me. I'm hiding in a back room in the operating room. So forgive me if there's noise and stuff. I'm wearing my AUA guideline hat today, and I'll talk to you about how the AUA SUO early detection guideline addresses the increased risk for African American men. I don't have any relevant industry disclosures. I think more importantly, some of the slides that I'll show you are from my teammates in the course we give at the American Urological Association. Their names are there. Simpa Salami is among them. And that this reflects the work of the entire guideline panel. I want to start just by reiterating what Dr. Crawford said. Prostate cancer is a big problem. Why? Because of high incidence. More prostate cancers are diagnosed than any other cancer among men in the US, and it's about 60% higher in African American men than white men. And high mortality is the second highest cause of cancer death in the US among men. And as we heard, about twofold higher in African American men, and that's variable by age. What does prostate cancer screening and early detection do? It saves lives, and that's pretty clear. I'll show you some information on that. And I would say that the efforts in screening over the last 20 years or so have reduced mortality overall, but specifically, if you look in the African American population, they've reduced mortality in that group, in that particular group. However, the more we screen, the more we find the clinically significant cancers, but we also find more of the clinically insignificant cancers, those low risk Gleason 3+3 cancers. And that we term overdiagnosis. And if you're diagnosed with them, you're at risk for overtreatment, meaning when we treat those low risk cancers, we're probably doing people a disservice. So we have to think about screening as a benefits and risk calculation. On the benefit side, there are studies from Europe showing that screening reduces the risk of prostate cancer death by 20 to 40% compared to not screening. And these graphics are showing the incidence of mortality in this group. This is the control group that didn't get screened, and this is the group that did get screened. And you can see that's lower. How much lower? Like I said, it's 20 to 40% if you compare the numbers, but those numbers are risk of dying of prostate cancer about 2.1% in people who are not screened, drops down to about 1.5% in people who are screened. And that's similar in the Swedish study. The problem is there's no information on diversity in these studies. And frankly, recruiting from places like the Netherlands, Sweden, and Finland is really not informative for African American men in the US. There's a US study that was flawed. Probably many of you know about this. It's called the PLCO study. And you see there's no separation between the control group and the group that was screened. Why is that? Well, what others have shown is that about 90% of the men who were not supposed to get screened were also getting PSA tests. So that really didn't work out in the US study, but it gives us a glimpse of one of the things that Dr. Crawford was talking about, which is enrollment in studies among African American men. The US study, look at how many people it included. It included 76,000 men but only 4.4% of those men were Black, non-Hispanic. And so we're sort of underrepresenting people in the studies, and therefore the recommendations that we make based on those studies can't be as precise as we would like. And so I think we can do better than this. I came up with African American men being 12% of the male population, but it may be even more than that. In any case, 4.4% accrual is too low. So again, prostate cancer detection is controversial. We balance the benefit and harm. We want to find the aggressive cancers early because we know there's a survival benefit, but we want to avoid unnecessary testing related complications, and what I call over detection and over treatment of those low grade indolent cancers. Those are the harms. The other reason it's controversial is because it changes all the time, right? There are new biomarkers, imaging, new biopsy techniques. So the guidelines have to account for all of these issues. If you look back a couple of decades, in this spike in incidence, where we thought, man, when we use PSA, we can find all these prostate cancers. So we screen everybody. We would biopsy anyone with a high PSA or an abnormal rectal exam, and then we would treat all those cancers. So what we saw is a big jump in the number of cancers detected, and frankly, a big drop in prostate cancer mortality, which you see here on the right, this brown line. You see that mortality curve drops by about 50%. So we did some good, but at the cost of probably over-treating a lot of men with low-risk cancer. Now, the guideline that we created here recently for the AUA aimed to balance these benefits and harms. Emphasis on identifying clinically significant cancer, age and life expectancy based recommendations. So we're not screening people who are so elderly that they're not going to benefit from it. Recommendations now specific for those at increased risk, including African American men. And then it goes into use of biomarkers, MRI, transperineal prostate biopsy approach, and the use of active surveillance for low risk cancers. So I'm going to go through some of those recommendations. And as I do so, I'll show you in red what's recommended by the AUA, in green what they say is optional in the guidelines, and then I have my little editorial comments in blue. So here's the basic paradigm, and this is all guideline. These are all supported in the guidelines, recommended statements in red. So shared decision-making is the beginning, a discussion between the doctor and the patient, maybe their partners or caregivers, about risks and benefits of screening, and incorporating your preferences into that. And then the screening test that we start with is the PSA blood test. That's the beginning. And the prostate exam is considered optional in the newest guideline. Why? Because it doesn't seem to add all that much to diagnosis. Once in a while, we'll find a prostate cancer on digital rectal exam that we wouldn't have found by the PSA blood test alone. But frankly, it deters some people from getting screened, and it doesn't add a whole lot. And then we recommend biopsy if the PSA is high or the prostate exam is suspicious. Now we'll get into some of the details and how this gets specific for African American men in a second. So when do we start? The age that's recommended to start is between 45 and 50 years old for men at average risk. But what about men at increased risk, such as those with Black ancestry, cancer-related genetic mutations, strong family history? Those men should start a bit earlier, at 40 to 45 years old, get a first PSA test then. And let's see, let me advance. And then when do we stop? Again, for men for both groups, average risk and increased risk, they say to personalize the stopping age. And here I think I have my editorial comment, which is we really should stop screening when life expectancy is less than about 10 years. And if you look at the Social Security life tables, that takes place around age 76. But of course, it's totally variable from one person to the next, so you never know with an individual. Certainly, we can agree that using a higher threshold for biopsy among older men is sensible. What about the frequency of screening? So for men at average risk, they say between age 55 and 69, we should be screening every 2 to 4 years. And that comes from that European trial, those European trials that I showed you earlier. And that surprises some people because most people are used to getting a blood test every year for PSA, which isn't wrong. But what they're emphasizing here is that if you test every year, you're more likely to pick up those low-grade cancers we didn't want to know about. And if you just screen every 2 to 4 years, you're probably not going to miss many of the higher grade ones. Well, what about men at increased risk? Here, the emphasis is on personalizing the frequency. So, if somebody is at higher than average risk because they have a higher than average PSA before age 55, African ancestry, cancer-related genetic mutations, or strong family history, these are the men who should probably be screened every year. I mean, that's, but it can be personalized from one individual to the next. Bottom line is earlier and more frequent screening is appropriate for men at higher risk. However, we have to keep in mind that when you increase detection of clinically significant cancers, you're going to also find the clinically insignificant ones. What is an elevated PSA, or what do we do with an elevated PSA? Always repeat a first-time PSA elevation, because almost half of them go back to normal. We don't want to overreact to just a random bump in the PSA. And if I'm repeating the PSA, I often get what's called a free and total PSA. Percent free PSA sort of gives you a hint about whether the PSA elevation is from cancer or whether it's from enlarged prostate or other causes. And then this is important too. Don't treat with antibiotics unless somebody's symptomatic. There's some people have this knee-jerk reaction, elevated PSA, give them antibiotics in case it's an infection. And unless there's evidence of infection, we shouldn't be doing that. Now, what's the appropriate threshold for a biopsy? I'll tell you that none is specified in this guideline. They leave it up to the clinician and the patient to decide. The European trials that I showed you earlier that demonstrated a survival benefit for screening for prostate cancer showed that they used a threshold of 2.5 or 3 to trigger a biopsy. And again, this surprises some people because traditionally we used to say 4 or above for everybody. But again, keep in mind that this is for men age 55 to 69. And again, those European trials were heavily weighted toward white men. Some people have advocated, compare your PSA to the average in your age group for men without prostate cancer. And these are surprisingly low. I mean, you may not have thought that the average PSA for a man in his 40s is 0.7, average in the 50s is 0.9, average in the 60s only 1.3, and in your 70s 1.7. That's for men without cancer. And actually, these numbers are similar in Black men as they are in white men, although there's a little bit more variability, particularly in the older age groups among Black men. But this puts in some perspective. When you come to the doctor and your PSA is 4 or 5, it puts that into perspective. So there's no uniform agreement on threshold. There used to be a historic threshold of greater than 4, and now most people are using somewhere between 2.5 and 3.5 to at least initiate a discussion about whether we should be doing something more. And then I typically use a threshold of 3 for men in their 50s and 60s, a little bit lower for men in their 40s, a little bit higher for men in their 70s. But again, there's no specific recommended threshold for men at increased risk. However, the guideline does recommend, it's optional, but it does recommend the use of risk calculators to guide shared decision-making. And I'll show you an example of that on the next slide, but these calculators incorporate African ancestry and acknowledge the increased risk among those men. And so along with age, PSA, rectal exam, prior biopsy, and family history. So let me show you what that looks like. Calculators, I think, are extremely valuable. They account for the increased risk posed by African ancestry. And I usually use this one called PBCG. And I'll show you that on the next slide here. This is an example where I just plugged in random numbers, age 62, PSA of 5.8, and so forth. And it'll give you an estimate of what's the chance of, they call it high grade, I would call it clinically significant prostate cancer. And what's the risk of finding one of the low grade ones that we would just watch? And what's the chance that the biopsy is negative entirely? So this is one way in which we can incorporate the increased risk posed by African ancestry into clinical decision making. And this is recommended in our latest guideline. I'm not going to go deeply into this, but instead of going straight from an elevated PSA to a biopsy, there are other options. There are blood and urine tests primarily to further risk stratify. Let's say your PSA is somewhere between 2.5 and 10, and we're trying to figure out, does this man really need a biopsy, or is this really due to an enlarged prostate or something? There are these tests that can further risk stratify people and say, your PSA elevation is likely to be due to prostate cancer, so we should do a biopsy. And there's one that we use if somebody's had a prior negative biopsy, we can actually test the tissue. Most of you probably know that we often use MRI to guide our biopsies, either before the initial biopsy or sometimes before a repeat biopsy. And my 2 cents here is that I only use the biomarkers if the results will change management. And I would just give the example of that patient I showed before, an African-American man with an elevated PSA. I probably wouldn't rely on one of these biomarkers, as good as they are. I would probably want to do a biopsy in that gentleman to make sure that I'm not missing something important. So I only use them if the result is, and again, if the risk is very low, somebody has a PSA of 1.5, usually the biomarker wouldn't sway me to do a biopsy. So, and then I do use MRI frequently, even before an initial biopsy. It's optional, but I use it commonly because I figure if the biopsy is negative and the PSA is still concerning, often my next move would be an MRI and another biopsy. So I think in some respects it saves a step. So if that's available, I use it. This is critically important. So we put in a specific recommendation saying that in men considering biopsy, they should be informed of the chance of finding low-risk cancer that can be safely monitored and doesn't require treatment. Somewhere around half of our biopsies show low-grade prostate cancer, for which active surveillance is the preferred management. Critically important. I always do that. So just to summarize it, and so the other folks in this panel session can get a chance to talk, the AUA SUO guideline provides an evidence-based set of recommendations that help guide clinical decisions and practices. There have been some modifications from previous guidelines that may help early detection in African American men. Earlier age to start screening at 40 to 45 instead of 45 to 50, and the use of risk calculators that account for increased risk among African American men. However, does this go far enough? Of course not. We have limited data on effectiveness of screening in underrepresented populations, and that's just a limitation. We can't make guidelines if we don't have data to base them on. So a lot of this is extrapolated from studies on mainly white populations. So we can do better on study accrual and study design to work these things out. And I'll just end by saying this is the way to access the guidelines if you wanted to look at it online. And these are the members of the guideline panel, including Dr. Salami, who is speaking next. And I thank you for your attention. Once again, thanks to Mr. Farrington and all the others who organized this great conference. So much appreciate my opportunity to be involved. Thank you.
Thank you so much, Dan, for participating again this year. And your comments have always been very, very helpful, and as we try to sort of find our way through this very, very difficult I appreciate journey. So thank you very much.
Thank you. And I'll be in and out for the rest of it. Sorry, I can't stay for it all.
Thank you.
All right. Thank you.
Okay. Dr. Salami, you want to start?